last topic on this session by Dr. David Richard Bell on malaria diagnostic, progress, possibilities, and priorities. I think malaria is a very common problem all over the world, or in India it is the most common disease. So definitely we should know the diagnostic and the priorities in malaria. Over to you, sir.
Thank you. So I'll try to give a brief overview of where diagnostics are at the moment, where they might go. So firstly, just a reminder of where we are with malaria in general. This is falciparum 19 years ago, according to the Oxford MAP project. So mostly in sub-Saharan Africa, but a fair bit still in Asia, South America. This is where we are a couple of years ago. So there's a lot of progress in Southeast Asia, in India, almost none in Papua New Guinea, very little really in sub-Saharan Africa. And this is, actually it's in the next one I think, so we'll just go to Vivax, which there's a lot, predominantly in Asia, South America. As a reminder, there's actually more than is shown there probably in Africa, so it's being recognised much more in East African countries as a sort of low-level co-infection with falciparum. So Vivax sort of has gone a little bit the same way, but there's a lot more persistence in Southeast Asia. If you look at, for instance, Venezuela there, it shows how fragile things are as well, because that, both in falciparum and Vivax, is an example of where things can get worse if the effort is taken off a bit. So we have some progress. Ovali is mostly in West Africa, but is scattered almost everywhere that malaria is, certainly in Asia, at a very low level, keeps popping up. Nolzi, so malaria almost everywhere as well, where falciparum is. Nolzi in Southeast Asia, and there's a few case reports in the very east of India, around Assam area. So we have a fair bit of progress, particularly in Asia, particularly in Southeast Asia, but also India on both of these, but particularly falciparum, but it's fragile. So if we look globally, there was a gradual decline in malaria mortality and in incidence over the last, well, this is since 2010, but it's flattened out over the last few years, and the World Malaria Report actually says that there's a slight increase in malaria over the last 2 years, which is a depressing fact when we consider the huge effort that's gone into malaria over the last, or since about 2003-04, when the Global Fund really kicked in and massively increased malaria funding. So there was a lot of progress. There's a lot of talk of elimination. Eliminations happen in places like Sri Lanka and will happen in some other countries that are on the edge of malaria. But overall, the global burden is not going down. And on the right, it just shows that particularly in sub-Saharan Africa, things are going quite badly again. So that's where most of the increase over the last few years is. There's one country in this region, Indonesia, that's had a very slight increase. So, India is, like others, is one of the countries that is making progress. And another reason for the fragility, or another reason for concern, is that most of the increase in funding is in development assistance. So it's external funding from the Global Fund, USAID, etc. And as we know, these are very fragile. They're dependent on donors wanting to keep donating to other countries and wanting to donate to malaria. So we can see from what's happened over the last few years that any reduction in funding is very likely to lead to a resurgence, particularly in sub-Saharan Africa, but also elsewhere. So there's progress, but there's also worries. So getting back to diagnosis, there's two reasons for diagnosing malaria. One is for case management. Someone comes with a fever, you need to know if it's malaria to give anti-malarials, or you need to know it's not malaria to do something else to help the patient. Also elimination, where we talk about detection of parasites, asymptomatic infections of falciparum and to a lesser extent vivax, so the ability to detect them to more rapidly reduce transmission, and to track transmission levels in population and know whether interventions are working and where to concentrate resources. So I'd like to go through both of these over the next few minutes. So if we consider from very high endemic malaria to low endemic, we're going to use these different diagnostics at different times. The case management obviously everywhere, but really concentrated where the burden is high. We need better survey and surveillance tools, particularly as the burden becomes low and malaria geographically is very heterogeneous. We need to know where to put resources, and rather than having a blanket approach over a whole country. So screening of asymptomatics, it probably makes sense where transmission is very low. Border screening is attempted by some countries, particularly where they're very close to or have eliminated, such as Sri Lanka, which will need a different type of tool. And there's a need for improved drug efficacy monitoring so that we can detect very early lowering susceptibility of the parasite to drugs. So all these technologies have different specifications in terms of sensitivity, specificity, different challenges in implementation, and also different willingness to pay, which is an important issue when it comes to where we put our priorities. So briefly for case management, we really have two options at the moment. So light microscopy, which has been around for about 150 years and hasn't really changed much. We still stain with much the same stain, GM-based stain, or JBS here, but Romanovsky type stains. You can quantify parasites, it allows species differentiation, so in a way it's the ideal diagnostic for case management, but it's very highly technician dependent. The threshold of detection isn't low unless you spend a lot of time on the slide and you're very good at it, and it's relatively slow for a point of care. If someone comes with a fever, they need treatment, and microscopy isn't a great answer to that if you want to treat them on the spot. And there's efforts to digitise microscopy, and some of them are promising, particularly for standardising for drug efficacy monitoring, etc. But none of them are going to be cheap. You still need to stain a slide in most cases. So they don't take away all of the drawbacks of light microscopy. And it's very relevant here because about half the world's microscopy is done in India, so about 100 million slides a year, with about 1 or 2% positive. So this is it's a study from Tanzania in 2007, but microscopy is the same now and the problems are the same. So this was based on field microscopy in clinics, the positive rates among people coming with fever. And these were cross-checked against expert microscopy and RDTs, and as you see, the original microscopy is almost worse than flipping a coin. And this is repeated in quite a lot of studies in sub-Saharan Africa. There's less studies on microscopy accuracy done elsewhere, but probably it's pretty similar everywhere. Where you're trying to do it in a clinic, you've got relatively low parasite, positive rates, but a lot of pressure to produce a positive diagnosis in some situations on the technician. So microscopy is, although it's possible to be good, in the field is very poor. And to make it work, there's a lot of issues that go into good microscopy, from the training and competency of the person to the supervision, the quality of the microscope, the reagents, etc. So it seems simple, it seems cheap, but very good quality diagnosis through microscopy is difficult and expensive. The alternative is rapid tests, which were first introduced in the 90s, lateral flow assays. Most for falciparum detect histidine-rich protein 2, which we'll come back to. So this was in all, we thought, is in most falciparum in fairly high concentrations in the blood of someone who comes in with a fever. Lactate dehydrogenase, which can be genus-specific or species-specific, is produced by all species. Aldolase really isn't used anymore, and there's been some efforts to find other antigen targets, but none have really worked out. So we're really looking at histidine-rich protein 2 for falciparum and lactate dehydrogenase for other species. Like microscopy, there's a lot of issues. They work well in theory, but getting them to work in the field is not so simple. There's been a pre-qualification or product testing scheme from WHO which will tell us in theory which ones are good quality and well manufactured. There was most public sector procurement was lot tested. Now that's sort of fallen apart, except in India where the NIMR continues to do lot testing. So at least in this country, you can tell when they come into the country whether they're performing well enough before you send them to the field. And it's really only India and a little bit in the Philippines that do that now. And lastly, understanding the issues of users and the accuracy there. So this is the product testing results from about 8 rounds that the WHO is doing. They've just ceased doing this now, but this is up to date. So this is, in the line in green is, well, first it tells you there's a lot of products out there, somewhat more than you'd think we'd need. And secondly, most of them detect almost all the samples. So this is the products along the bottom, they're detecting samples at high and low parasitemia in a bank at CDC, and it's run by WHO and FIND. There are a few that detect all the samples on the left, and then it sort of deteriorates on the right. But there's a few very good RDTs that, at least against that sample bank for falciparum, are very accurate. So does this mean they're safe to use? This is a series of studies from, I think, all in sub-Saharan Africa, but looking at if you treat, if you use an RDT and then you don't give treatment if the test is negative, and in children, and in all of these studies there was no mortality attributable to any failure of RDTs. So we can fairly confidently say that if they're good quality RDTs, they're sensitive enough in a clinical malaria to safely withhold treatment on a negative result. 5X is slightly different, so there's a number of tests that do very well against the WHO panel. There's also a lot of 5X detecting tests out there. But almost uniformly in the field, they're getting about 75 to 80% sensitivity. So we have a problem with 5X. We're missing a lot of 5X when we rely on RDTs. Probably microscopy in good hands is better. And as I said, getting these to the field and working, we can also make a lot of gains. So this is some studies from a few years ago looking at if you actually do good training on health workers and if you have good instructions for health workers, you can greatly increase sensitivity. This is going from 60 or 70% up to 90, 95%, just by improving the training, improving the instructions, which people often forget, but which is, you would see from this, is probably more important than choosing the correct tests in the first place. So we can't just send these out. So a few challenges or threats in case management. Firstly, in Vivax, they're insensitive. We're missing about 20% of Vivax. We also can't, there's no test for latent Vivax. We would like a latent test so that we can give an aminoquinolone such as primaquine, so that we can stop people relapsing. This has become more important with the release of tefenaquine, which is a long-acting aminoquinolone, and we have to have, there are risks with that. We will need a G6PD test. We can only give it to people who aren't G6PD deficient, because unlike primaquine, if they start hemolyzing, you can't withdraw the drug. And we don't have a G6PD test that's useful at a clinic level. So we have a big gap with 5X. We're missing about 20% of symptomatic cases. We can't detect latent infection. Most of these cases will go on and relapse, and when they relapse, they will transmit to other people. So if we could get a much more sensitive in 5X, even just in symptomatic treatment, we would also stop a lot of relapses. We might very significantly and rapidly reduce 5X transmission. Secondly, HRP2 deletions, and these were first identified. So this is in nearly all tests on the market at the moment, this is how we detect falciparum. And about 10 years ago now, it was recognised in the Amazon region that there's quite a few parasites that don't produce HRP2 and are undetectable by these tests. And they weren't selected by the tests. They're probably there for about 20 or 30 years, and they do perfectly well without HRP2, so I think no one's really sure what HRP2 does. This more recently was noticed in about 30% of cases in Eritrea, where they were noticing that RDTs seem to be failing, and there's also significant deletions in Ethiopia. So this is a genetic deletion, it's a mutation. It seems to be happening sort of spontaneously in different places. It may be that HRP2 tests as a basis for treatment is selecting for it to some extent. There's also quite a bit in DRC. And more recently, so there's a paper come out late last year showing quite significant rates of deletions in Odisha in India. So probably this isn't spread, no one knows, but probably they are just arising spontaneously, and perhaps the use of rapid tests is helping them to spread. But this is a real threat because HRP2 tests will, in Odisha in this particular study, they weren't working in 30% of people with malaria. So we need to go back either to microscopy in that case or to have a better test such as an LDH test that's sensitive enough also for falciparum. So it's not, in most countries they're fine, but it's an emerging and quite worrying trend. So just to move quickly to elimination, and this is from Im Wong and others in Southeast Asia, from Moru people. So this is showing the distribution of parasites in symptomatic and asymptomatic people. The people with red spots are symptomatic, the rest are asymptomatic. And parasite density on the left. So we're seeing that in this study there's a lot of people that are at 2 or less than that parasites per microliter, and these are asymptomatic, most of them. So it's in a community with relatively low apparent transmission, but there's actually a very large reservoir of asymptomatic parasitemia. We know that some of them at least transmit to other people. So, and most of these won't be picked up by passive case detection looking for people with fever. So an RDT or microscopy, field microscopy will pick up most of the symptomatics, but it's just the tip of the iceberg perhaps of actual infections. PCR will get down to about a parasite per microliter reliably, so we're picking up most of them. So there's a bunch of people there, even if we screen with PCR, who are parasitemic, but we're not going to find. Whether these matter or not, whether they're likely to transmit, probably when they're very, very low parasite densities, they're less likely to transmit, or we know that. But they may also be much higher densities in a couple of weeks' time because these infections tend to fluctuate. So if we're going to go to screening and try to accelerate elimination that way, we have this problem of being sensitive enough. And this is a graphic of a typical infection. So with falciparum, if you don't treat it, it'll stay for many months often. It'll fluctuate in parasite density. You'll get fever with some of those fluctuations. Malaria, microscopy or RDTs will pick up really when they're symptomatic, but it's just, it'll miss that patient for a lot of their infection. PCR will pick up most of it, but not all. If we wanted to pick up every infection, we need a quite different approach, a different platform, which we don't have now. So if we going to screen, I'll come to that in a moment, but the idea of screening to try to eliminate elimination has been popular since it was sort of really became clear that there's this large asymptomatic reservoir in the last couple of decades. So if we had a very sensitive test, how would we use it? And this is a little bit idealized, but the idea of passive surveillance around, of active surveillance around clusters. And we know that malaria, it clusters it's been shown, for instance, in Swaziland, that if you have someone who's infected, you will find other infections sort of clustered around that house, but not further away, with a fairly high frequency. If we have a very sensitive test, we could potentially fairly efficiently just screen around those houses. We'll find people who have very low densities. Or screen around a breeding site near where we know that there's cases, and potentially accelerate elimination. So if we have a much more sensitive test, and we have the money to implement that, there's a potential to actually actively go and screen, find these asymptomatic reservoirs and greatly increase the rate in which we eliminate. So another alternative is to use antibody serology tests, and they won't tell us that the person's infected, but they'll tell us that the person is infected or has been infected in the last several months or couple of years. And if we have such a test, we can then potentially very cheaply screen very large areas, identify where the hotspots are through where people have higher antibody rates, and then go into those areas and do screening with a very sensitive test. So to do this, we're going to need different technologies than we have now. PCR is not practical in its current forms as a laboratory-based test. We haven't got the microscopy and rapid tests aren't sensitive enough. So very quickly looking at the options for this and for improving case management. We really have PCR and LAMP, so nucleic acid amplification tests, improving lateral flow, or various other emerging technologies. There's a couple of LAMP tests on the market now for malaria. They will go down to 1 or 2 parasites per microliter. They're relatively easy to use. You can get closer to a patient than you can with laboratory-based PCR. But they're not really cheap and they're not really simple. And the Aiken one at the top, for instance, is about $5 per patient, $5 per sample. So they're allowing us to get much closer in surveys for low parasitemia, but they're nowhere near as cheap as we need if we're going to survey thousands of people. Cassette-based PCRs is an example of the Quantum platform from the UK. So it's a very simple cassette with relatively cheap, $4 or $5 potentially. At the top there, you put in the blood, put in the machine, press a button. In about 15 minutes, it'll give you a result. It'll multiplex to about 30 or 40 plex, go through about 35 cycles within that time of PCR, and run across a microarray for fluorescence and give you a readout. So in theory, with malaria, it could give species, etc. There's a test coming out soon for HPV and for STIs. They were working on a malaria test. They no longer are. And that comes down to the issue, one, does everyone want a $5 malaria test? And if you're screening thousands of people, that becomes very expensive. And the jury is still out on how useful it is to screen, and so how big is that market? So this is potentially a really useful test. You could go to the field and for $3 or $4 or $5 you could find, which species, etc., in 15 minutes on a patient. But it's really unclear, and the malaria community sort of can't get its act together, I think, on whether this is going to be useful, and so does it make sense for a company to invest in getting this out into a product? There's one very sensitive rapid test on the market, which in some studies is very sensitive and some studies is not so sensitive. But it's an improvement on current tests. It'll get a little bit further down towards where PCR is. And there's a number of product development efforts for serology tests, both for falciparum and Vivax. But all of these will suffer from the same issue that it's really unclear, I think, which countries will use these, how they will be used, and so there's a lack of push, there's a lack of incentive for manufacturers to really take this on and get them out as successful products. One last example of going in a different direction, this is hemozoan detection, so all malaria parasites produce hemozoan as a byproduct. It's in the food vacuoles. This is from Hemex Health in the US. It's actually going to be tested by Manipal in the next few months. So this is interesting. It's 1 minute from sample to result from a finger prick. It's about as sensitive as falciparum as sensitive as rapid tests for falciparum, considerably more sensitive for Vivax. So it's one of the tests that may get us to where we want to with Vivax sensitivity. It needs a reader, but it's a 1 minute test. So it's interesting, it very much could change the workflow of clinics if you're using this. So there's a current trial in Peru, there's some early results there, and from Mumbai where it significantly outdoes rapid tests on a mostly Vivax sample set. There's a very large study also in India, about 5,000 cases. It will start in a few months. So just to summarise, we have reasonable case management tools, but we have a real threat with falciparum with HRP2 deletions increasing, and we really need to rethink Vivax to have much more sensitive tests if we go into accelerate elimination of Vivax. And everything, globally we're stalling with malaria. We can't afford to just keep stalling, so there is a real need for a rethink on how we do this. In terms of elimination, we haven't got good tests for screening for high sensitive, for asymptomatic infections, and there's some movement in that direction, but there's not enough momentum probably to get one in the near future unless the malaria community really decides that this is a priority and makes a market for it. So this really depends much on the mood of the funders. So I guess in summary, it's more worrying than it was 10 years ago for a number of reasons. And there's a few things in the pipeline, but there's a real need for much more focused product development. Thank you.
Thank you, Dr. David. That was an excellent presentation on various diagnostic aspects. Open for any questions from the floor.
Regarding this rapid diagnostic test, sir, like nowadays we hear about Plasmodium null-C also. So are they capable of diagnosing those, the rapid diagnostic tests?
Yeah, so it's a problem. I mean, it's a problem on the very east of India, perhaps. It's a problem in Malaysia, in parts of Indonesia. They do produce lactate dehydrogenase, and they would, so it's certainly some lactate dehydrogenase tests detect them. They also produce hemozoan. A hemozoan detecting test would also detect them probably fairly easily because they produce a lot of it. So yeah, probably the current LDHS, there's a couple there which are usable. None of them are as sensitive as we'd like. I think most diagnosis still at the moment is suspicious, looking on microscopy and then confirmed by.
Okay, so in the past or several years ago, we used to tell malaria diagnosis is very simple. Do one thin smear, thick smear, look for the parasite and give the diagnosis. But now the diagnostic tests have become so many, I think nothing is, or not even one single test will be really making a diagnosis. So the costs are going more and more. So sometimes I feel in our system or in our Indian scenario, maybe treating malaria on an empirical basis may be cost effective rather than going for all these tests. Okay, I conclude this session.